If you're taking a blood pressure medication right now, especially one you've been on for years, there's a side effect your doctor almost certainly never mentioned, and it's happening to your eyes. Stay with me, because what I'm about to show you is something I wish I'd told patients sooner. I am Dr. Warren Hung, a medical doctor, and this is one of those topics that gets oversimplified or skipped entirely in the average 15-minute appointment. If you want clear, medically grounded explanations on health issues that actually affect your daily life, subscribe to this channel. New videos go up regularly, and every one of them is built to give you real understanding, not just reassurance. Now, back to what I was saying. Blood pressure medication is one of the most prescribed drug categories in the world. For people over 60, it is extremely common to be on at least one of these medications, sometimes two. And the conversation around them almost always focuses on the same things: keeping your numbers in range, protecting the heart, avoiding a stroke. Those are real and important goals. Nobody is disputing that. But there is a part of that conversation that gets left out. Not because doctors are hiding it, not because it is classified information. It gets left out because most clinical appointments are short, because the connection between blood pressure drugs and eye health is not covered the way heart risk is, and because the damage when it does happen moves so slowly that neither the patient nor the doctor connects the dots until something more obvious shows up. That is the problem: slow, quiet, and invisible until it is not. The eye is one of the most blood supply dependent organs in the human body. The optic nerve, the structure that carries everything you see from your eye to your brain, requires a steady, consistent flow of blood to stay healthy. The retina, which lines the back of the eye and captures light, is packed with tiny blood vessels that are exquisitely sensitive to pressure changes. These structures are not protected by extra redundancy the way some other organs are. When their blood supply gets disrupted consistently over months and years, the damage accumulates quietly. Now, here is the part that surprises people. The issue is not high blood pressure causing the damage to the eye, though that is also a real concern. What I am describing is almost the opposite situation. It is blood pressure being pushed too low, or dropping too low at certain hours, that can starve those eye structures of the blood flow they need. And in many cases, that drop is being caused by the medication itself. This is not a rare or theoretical risk. Research published in ophthalmology and cardiovascular medicine has looked at the relationship between aggressive blood pressure lowering and optic nerve damage, and the findings are consistent enough that eye specialists have a term for the pattern. The concern is real, it is documented, and it is underreported in the conversations patients are actually having with their doctors. The people most likely to be affected are not those with poorly controlled blood pressure. They are people who are, on paper, doing everything right. Their numbers look good. Their cardiologist is satisfied. Their medication is working exactly as intended. And yet, quietly, without a single dramatic symptom, something is shifting in their vision that they have not been told to watch for. If you have been on a blood pressure medication for more than 2 or 3 years, particularly if you are over 60, what happens inside those eye structures and exactly which medications carry the highest risk is something worth understanding clearly. To understand why this matters, you need a basic picture of how the eye gets its blood supply and why that supply is more fragile than people realize. The optic nerve sits at the back of the eye. It is the cable that transmits visual signals to the brain. Like any nerve tissue, it needs oxygen. It gets that oxygen through a network of small blood vessels that feed it continuously. The retina, which is the light-sensitive lining at the back of the eye, has its own separate but equally delicate vascular system. Both of these structures, the optic nerve and the retina, depend not just on blood pressure being present, but on it staying within a specific functional range at all times. Too high causes one set of problems. Too low causes another. The concept you need to understand here is called ocular perfusion pressure. It sounds technical, but the idea is straightforward. Ocular perfusion pressure is the difference between the blood pressure pushing blood into the eye and the pressure inside the eye itself, which is called intraocular pressure. When that difference is large enough, blood flows freely through the optic nerve and retina. When that difference shrinks because blood pressure drops significantly, the eye's internal pressure starts to win, and blood flow to the optic nerve gets restricted. That restriction is not like a heart attack. It does not announce itself. It happens gradually, over months or years, and the optic nerve loses fibers slowly enough that the brain compensates without the person noticing until the loss has passed a threshold that compensation can no longer cover. Now, here is where blood pressure medication enters the picture directly. 2 categories of blood pressure drugs are most associated with this risk. The first is beta blockers. These are medications like metoprolol, atenolol, and carvedilol. Beta blockers work by slowing the heart and reducing the force of its contractions, which lowers blood pressure. They are widely prescribed and genuinely effective for cardiovascular protection. The second category is certain calcium channel blockers. particularly those that act strongly on the blood vessels themselves rather than the heart. Amlodipine is one of the most commonly prescribed examples. Both of these drug classes can, in some patients, push blood pressure lower than the eye's perfusion system can comfortably handle. And there is a timing element that makes this more complicated. Blood pressure naturally drops during sleep. This is a normal and healthy pattern. The medical term for it is nocturnal dipping. For people who dip within a normal range overnight, roughly 10 to 20% below their daytime readings, this is not a problem. But people who dip excessively, what clinicians call deep dippers, can see their blood pressure fall significantly below the threshold the optic nerve needs during the hours they are asleep. These are hours when nobody is checking. There are no symptoms to notice. The person wakes up feeling fine, takes their morning reading, sees a reasonable number, and the night's events are invisible. When someone is taking a once-daily blood pressure medication dosed in the evening or at bedtime, which some guidelines have recommended because nighttime dosing can offer cardiovascular benefits, the medication's peak effect often lands squarely in those overnight hours. That combination, an already dipping blood pressure and the peak effect of a medication, can push ocular perfusion pressure down to a level the optic nerve was not designed to sustain repeatedly over years. This is where the term low-tension glaucoma becomes relevant. Standard glaucoma is associated with elevated pressure inside the eye. Low-tension glaucoma, also called normal-tension glaucoma, involves optic nerve damage that happens even when eye pressure appears normal. Researchers studying this condition have found a meaningful overlap between patients with low-tension glaucoma and patients with a history of significant nocturnal blood pressure dipping. The eye pressure looks fine on a routine check. The optic nerve is still being damaged, and the driver, in a significant number of these cases, appears to be inadequate blood flow during sleep. What makes this particularly hard to catch is that the standard tools used in blood pressure management office readings, home monitors, even 24-hour blood pressure monitors, if not analyzed carefully, do not automatically flag what is happening to the eye. A cardiologist sees controlled blood pressure and a protected heart. An eye doctor sees normal pressure readings and may not ask about blood pressure medication timing. The two conversations happen in separate rooms, and the patient carries the gap between them without knowing it exists. That gap is exactly where this damage lives. And once you understand that the problem is not simply about what your blood pressure reading says, but about what happens to blood flow in specific tissues at specific hours of the night, the question of who is most at risk and what signs to watch for becomes a great deal more urgent. The frustrating thing about this type of eye damage is that its early warning signs do not feel like eye disease. They feel like aging. And because they feel like aging, people accept them. They adjust. They compensate without realizing they are compensating. And the window where early intervention could make a real difference quietly closes. The first sign worth paying attention to is gradual peripheral vision loss. Not sudden, not dramatic, gradual. The outer edges of your visual field start to shrink slowly enough that your brain fills in the gaps automatically. You may not notice it until you bump into something on your side that you genuinely did not see, or until a routine visual field test at an eye appointment shows a pattern of loss that surprises you. People often describe looking back and realizing they had been turning their head more than usual to compensate for months before anyone caught it. The second sign is difficulty adjusting to low light. Walking into a dimly lit restaurant and needing significantly more time than you used to before your vision settles. Driving at dusk and finding it harder than it was 2 or 3 years ago. The optic nerve and the retinal cells, responsible for low light vision, are among the most metabolically demanding in the body. When their blood supply has been chronically reduced, their ability to adapt quickly degrades first, before other vision functions do. This is not a symptom people typically report to a doctor. It goes in the same mental folder as getting older. The third sign is occasional blurring that comes and goes without an obvious explanation. Not consistent enough to feel alarming. Not tied to a specific activity or time of day in a way that would make someone call their doctor. Just intermittent enough to be easy to rationalize and easy to forget. None of these three signs will necessarily send someone to a specialist immediately. That is precisely what makes them dangerous in this context. They are real early signals of a real structural problem, and they are almost perfectly designed to be ignored. Now, who carries the highest risk of this happening? Age is the first factor. After 60, the blood vessels that supply the optic nerve lose some of their ability to self-regulate. Healthy vessels can maintain relatively stable blood flow, even when systemic blood pressure fluctuates. Older vessels are less capable of that compensation. So the same overnight blood pressure dip that a 50-year-old handles without issue may push a 65 or 70-year-old into a range where optic nerve perfusion becomes genuinely inadequate. The second risk amplifier is being on more than one blood pressure medication. Combination therapy is common and often medically appropriate. But the blood pressure lowering effect stacks, and so does the overnight dipping risk. Someone on 2 or 3 antihypertensive medications is more likely to be a deep dipper than someone on a single low dose. The third factor is having both a blood pressure medication history and a pre-existing eye pressure condition, even if that condition is considered mild or well controlled. If the eye's internal pressure is already at the higher end of normal, and then blood flow into the eye is also being reduced from the outside by a medication-driven BP dip, the margin the optic nerve has to work with becomes very thin. Low diastolic blood pressure is the fourth risk marker. The diastolic number, the lower number in a blood pressure reading, is specifically relevant to the eye because ocular perfusion is closely tied to diastolic pressure. People whose diastolic consistently runs below 60, particularly during sleep, are in a higher risk category, regardless of what their systolic looks like. This is not something patients are routinely warned about when a medication is prescribed. The fifth factor is nighttime dosing. If you take your blood pressure medication in the evening or at bedtime, the timing of that dose may be lining up its peak effect with your body's natural overnight dipping window. This does not mean nighttime dosing is universally wrong. There is cardiovascular research supporting it, but it is a variable that has never been discussed in the context of your eye health. It is worth raising. Have you noticed any of these signs yourself? The slow drift in peripheral awareness? The extra time your eyes need in low light? The occasional unexplained blurring? If you have, it does not mean damage has been done, but it does mean you have information now that is worth taking seriously and worth bringing to the right conversation. Because there is something specific you can do about this. It does not involve stopping your medication, and it does not require guesswork. What it requires is knowing exactly which questions to ask, which tests to request, and what your doctor may be able to adjust that nobody has thought to adjust yet. That conversation is more straightforward than people expect, and it starts with understanding what to ask for. The goal here is not to make you distrust your medication. Blood pressure treatment saves lives. The research on that is not ambiguous, and nothing in what I have shared changes it. What I want you to walk away with is something more precise than fear. A specific, realistic set of actions that puts you in a better position than you were before you watched this. There are 3 concrete moves worth making, and none of them require you to do anything dramatic. The first is a conversation about nighttime blood pressure dipping and your current medication timing. This is the most direct lever available, and it is also the most underused one. When you see your prescribing doctor, whether that is your general practitioner, your cardiologist, or your internist, ask specifically whether you might be a deep dipper. A 24-hour ambulatory blood pressure monitor can answer that question. It is a small device worn on the arm for a full day and night that records blood pressure at regular intervals, including while you sleep. The overnight readings it captures are data your doctor may never have looked at in the context of your eye health. If the readings show significant nocturnal dipping, that is medically relevant information not just for your eyes, but for your overall cardiovascular management as well. If the monitor shows you are dipping excessively overnight, there are options. Medication timing can sometimes be adjusted. In some cases, shifting a dose from evening to morning changes the peak effect window enough to reduce the overnight dip without sacrificing blood pressure control during the day. This is not a decision to make on your own, and I am not telling you to change anything without medical guidance. What I am telling you is that this adjustment exists. It is reasonable to ask about, and your doctor may not have considered it from the angle of ocular perfusion. The second move is requesting an optic nerve assessment and a visual field test if you have been on blood pressure medication for 3 or more years and have not had one recently. A standard eye exam checks your visual acuity and your eye pressure. It does not automatically include a detailed evaluation of optic nerve health or a map of your peripheral visual field. Those are separate tests, and you may need to ask for them specifically. An optometrist or ophthalmologist can perform both. If there is early optic nerve thinning or peripheral field loss already present, catching it now, while it is still early, is far better than catching it after it has progressed to a point where daily function is affected. Tell the eye doctor that you are on long-term blood pressure medication and that you want the optic nerve specifically evaluated. That context changes what they look for. It tells them to take a closer look at the nerve fiber layer, to map your peripheral vision carefully, and to flag patterns that might otherwise be filed under age-related changes without further investigation. The third move is understanding your diastolic number more carefully. Pull out your last few blood pressure readings from home, from a pharmacy monitor, or from your last few doctor visits. Look at the lower number. If your diastolic is consistently running below 60, that is a conversation to have with your doctor directly. Not in a panic, but as a specific observation. Say, my lower number has been consistently in the 50s. Is that within a safe range for my eye health given how long I have been on this medication? That question alone may prompt a level of attention to the issue that a general check-in would not. What you are doing with all 3 of these moves is connecting 2 conversations that have been happening in separate rooms. Your cardiovascular care and your eye care have been managed independently, which is completely standard practice. The problem is that the eye is a vascular organ, and what happens to blood pressure at night reaches the eye the same way it reaches the heart. Bringing those two conversations together, even just by asking the right questions in each room, creates a more complete picture of what is actually happening in your body. This is also worth sharing with someone you know who is over 60 and on long-term blood pressure medication, not to alarm them, but because the gap between what gets managed and what gets checked is wide enough that most people in that situation have never had this explained to them. A simple conversation, did you know you can ask for a visual field test? Did you know about nighttime dipping can change what someone asks at their next appointment? The eye does not give you many second chances once the optic nerve loses significant fiber. Unlike some other tissues, the optic nerve does not regenerate in any meaningful way. What is lost tends to stay lost. That is not said to frighten you, it is said because it is the biological reality that makes early awareness matter more here than in many other health conversations. You are not powerless in this. The medication keeping your heart protected does not have to come at a silent cost to your vision. The tools to check this exist. The tests are accessible. The conversation with your doctor is reasonable to have, and the adjustments, if any are needed, are the kind that medicine can actually make. What was missing, for most people in this situation, was simply knowing that the question was worth asking. Now you know it is. If this gave you something useful, subscribe to this channel. I put out regular videos on the health topics that tend to get skipped or oversimplified in standard medical care. And if you are currently on blood pressure medication, drop a comment below. I read them, and it helps me understand what topics to cover next. Share this with someone who needs it. It might be the most useful thing they hear before their next appointment.